Are we live? Okay, so this is going to definitely be, you know, a little bit hit and miss. We're not only is it a joint committee, but half of it is virtual and half of it is here in Shire Hall. So good morning, everybody. My name is Andrew Gravel. I'm chairman of HOST. To my right, he will introduce himself later. We have Stephen Hurst, who is chairman of the Adult Social Care and Community Scrutiny Committee. We have an incredibly long agenda, lots of presentations, lots of key areas of NHS and social care work, a lot to get through. So no long speeches from me, and hopefully not too many long speeches from people who are going to contribute. I'm going to begin with Joe, looking at my left. Joe's our
administrator.
Well, I was trying to think of a much more interesting word, our sort of guru, our expert, our knowledgeable person. So, Joe, please help me. What apologies do we have for this meeting, please?
Thank you, Chairman. We have two formal apologies from committee members. These are from the members of the Health Overview and Scrutiny Committee. Apologies from Councillor Alan Priest, who is being kindly substituted by Councillor Andrew Miller, who is joining us via remote access. And we also have apologies from Councillor Jill Smith, who is our Tewkesbury Borough Council representative. And we're very pleased to welcome Councillor, please forgive me if I pronounce this right, Kija Belina, please. And so those are the only two formal apologies. We have a couple of apologies from officers. Sadly, Mary Hutton is not able to join us today. And we've got Ellen here, Ellen Rule, who's representing Mary. And we've also got, let me just see, I think that's it, Deborah Lee, as unfortunately not able to join us, but we've got Mark Petroni to represent Deborah.
Okay, Joe, any more apologies?
That's it, thank you.
No, any more apologies? Joe, just remind me, please, how the people who are joining us virtually indicate they wish to speak. Is it with the same old, please raise your hand and we notice the screen?
Yes.
It's that, that's how we do it.
If you wish to speak today, because we're remote access, you can either use your remote hand, you can raise your hand from your laptop, and I will be checking that. Or if you feel that you've not been noticed, if you just wave your hand in front of the screen, and I will advise the chairman. But on my laptop, I should be able to tell you.
Okay, hope that's okay for the people who aren't joining us here in Shire Hall. A quick word to David Drew. David, thank you for joining us. Thank you for your emails here. You're going through the wars a little bit with COVID, but thanks for making the effort to join us from home. So item 2, Joe, we have declarations of interest. Any declarations of interest that people wish to declare which haven't been declared previously, either here or virtually? Any? No, I don't see any at all. Okay, take that as a no. The minutes of the Health Scrutiny meeting held on the 11th of January. Those of you who were there, is it okay for me to sign those as a true record, please? All those in favour? Yep, that looks pretty unanimous. Those, you were all there as well. Got that? Stephen, can I let you introduce item 3B? Is that okay? 3B, the meeting of adult social care.
Can you hear me, everybody?
Yeah, yes.
My name is Stephen Hurst, and I'm the chair of the Adult Social Care and Communities meeting. First of all, we have to look at the agenda for the meeting held on the 25th of January. Can those members of the Adult Social Care Committee who wish to recommend that we adopt these minutes, please show now. Thank you very much, Mark. Lisa, thank you. Would anyone like to second that? You put your hands up again if you want. Anyone wishing to second that proposal that we adopt the minutes, please show. No.
You can second that.
I can second it. So that's done, isn't it? Thank you very much indeed. That takes care of item 3B.
Okay, thanks, Stephen. Thanks, committee. So, Joe, public representations, item 4. I don't think we've had any, none at all. Okay, so item 5, a major piece of work here, and I think that's going to be introduced by Eve. Is it Eve? Yeah. So Eve, over to you. A major piece of work.
Thank you, Mr. Chairman. Morning, everybody. My name is Eve Oliphant. I'm the Senior System Flow Lead at the ICS, and I'm delighted to be joined by colleagues virtually, Mark Hutchinson, who's the Exec Chief Information Officer at GHFT, and Chris Barrett, who's the Strategic Lead for Adult Social Care and Hospital Integration, who are going to support me in this presentation, just representing the work that we've tried to do across the ICS this winter. I will just give a brief overview. I'm aware that colleagues have received the pack already. Obviously, some of our key aims for Gloucestershire this winter were, in particular, to continue to maintain and improve our health and social care services, despite struggling again with the impacts of, obviously, COVID and the associated work challenges. Be fair to say this has been very difficult, but we have aimed to, in particular, work with 111 and triage to really develop our redirection services away from the front door, working with Swast colleagues. We've endeavoured to continue to expand and improve mental health services and services for patients with learning disabilities and autism. We've worked so hard across the system to deliver our vaccination programme, which I think has been really successful. And most importantly, we've worked very hard from a health and social care perspective to develop the collaboration between adult social care and the independent sector, including the voluntary sector. Obviously, as I'm sure colleagues around the table are aware, that despite of this, our position does remain very challenging. We have struggled throughout the winter with the impact of workforce, so we've struggled to recruit and retain into health. Our adult social care sector has really felt the impact of Brexit in terms of losing a lot of our domiciliary care workers who've chosen to return home. The impact of COVID on health, obviously, from a patient point of view is significant, but also the IPC regulations, the infection control regulations that we have to work to, has made patient flow within health, so within our acute hospitals and our community hospitals, not straightforward, so not the traditional sort of pathway that you would have perhaps experienced if you normally came into hospital. You may have been moved more times than you might have liked to because of the need to keep patients in their respective groups. And then from an adult social care and an independent sector perspective, obviously, the application of guidance around care home closures, around staff sickness, and our ability to then move patients into their correct onward pathways has resulted in long hospital stays, both at the acute hospital and our community hospitals. And we also know that we've got delays for our patients who have made it out into rehabilitation to then move on to home or their onward journey. So really across the whole setting, what we've experienced is a delay through so many parts of the process that the totality of that is obviously making things really difficult. However, in spite of that, we really have tried to innovate as a system across the winter. There's a number of schemes that have worked well, all of which have been supported from across the system with partners working really, really collaboratively. There's a couple of schemes I'd just like to draw attention to. In particular, the rapid response and Swast collaboration pilot. So this was a pilot between GHC colleagues and Swast colleagues, with our rapid response providers working with the specialist paramedics in their call centre to identify those patients who may have been referred on to an ambulance, but don't necessarily need to come into hospital, and what else could we possibly do to either direct them to our other services, our minor injury unit, or to treat them at home, so that we can absolutely, where possible, avoid bringing people into hospital, because we know that that's not the best place for them. We've seen some really, really good results from that small pilot, and we'll be looking to make that an ongoing piece of work going forward into this year. So Swast and GHC colleagues are working to bring that together more directly. We've seen a great improvement in terms of synapsis, so that's a phone system, for want of better words, so that GPs and community providers can contact specialist support at the hospital, so consultant-led support, so that they can either get treatment advice to redirect, or if the patient does need to come into hospital, to bring them into the best possible pathway. Which is not always through the emergency department. So obviously some of our same-day emergency care facilities are acute medicine. So there's so many different ways to ensure that we bring the patient in and we keep them as safe as possible and treat them as quickly as possible. In terms of our work with adult social care, we've seen a really successful pilot of the social workers are now working in ED to social care practitioners. And as colleagues will see, of the sort of 40 patients, the data we've had from the pilot that social care were involved with, social care supported 20 discharges of those 40 patients and redirected services. I'd just like to hand over, if that's okay, to Chris Barrett, my adult social care colleague, who would just like to talk through an example of how this has worked.
Good morning, Chair. Good morning, everybody. So we joined the ED department as a trial basis to see whether or not some of the skills that are specific to adult social care would be able to support the clinicians that work within ED to be able to stop people at the front door from actually coming in. And as this figure suggests, it has been a big success. One of the successes that I think I would like to point out an example is where a couple, a 93 and a 95-year-old, came in from home. They were on the hospital. There was a queue outside of hospitals, unfortunately, as there is at the moment. The clinicians had been onto the ambulance to make sure that they were clinically safe and that they were okay. And once that had been done, the social workers were able to actually get onto the ambulance themselves. They were actually able to discuss what it was that this couple required and what it was that was the issue. And then they were able to liaise with our brokerage service and get an assessment placement in the same home for both people, so that we could then assess them away from their home, but more importantly, they didn't have to enter into the hospital as admissions. So therefore, it was a successful way of being able to stop people being able to fall into that hospital admission and be able to move forward. And both of those couple have gone home now and are living back at home again. So it was a really successful intervention.
Thank you, Chris.
You're welcome.
Obviously, alongside that, we know that we've received funding from government, which the County Council has worked really hard to support recruitment and retention within social care. There's a number of key schemes listed, obviously, in the pack. We've worked very closely with our voluntary sector colleagues to improve our offer and to support patients out of hospital to their homes with wraparound support. The other key piece of work that we've really tried to progress this winter is the joining up of our information, if you like, across our systems. We all, certainly from an information point of view, work on quite different systems, and that can be quite siloed, and it can lead to a reduction in inefficiency and productivity from a staff point of view. It makes it really difficult for staff to do the best things for patients across the system. So we've worked collaboratively with GHFT colleagues to bring online a dashboard, if you like, where we're sharing the relevant information about patients from adult social care, from communities, from hospitals, so that our staff members who are trying their very best to get patients out and home and safe and well can do that in the best possible way. So I'd just like to hand over to my colleague, Mark Hutchinson, who would just like to outline some of the key work that we've done in that space.
Morning, colleagues and partners. My name is Mark Hutchinson. As Eve says, it's been really exciting just over the last couple of months to be able to see the difference that we can make for our colleagues as well as for citizens and patients by being able to share information between the different systems, between our different organisations, to help us plan ahead and be able to map the route both into, but then really importantly out of the acute hospital into the next place of stay for each of those patients. And this is really just the very first step. Sharing information is really important, but then being able to try and use digital solutions to be able to help us do the right thing for patients in every opportunity. I quite often tell people about growing up and being a toddler. Playing football with my gran was something I always enjoyed doing. We used the dining table as the goals. And she went into hospital for 2 or 3 weeks when I was quite young. And by the time she came out, having spent much longer than she should have done in hospital, I didn't get to play football with her again, although I did quite enjoy playing with the stair lift that she then got. The deterioration that she had experienced by being stuck in a hospital bed for those 3 or 4 weeks had a real impact on her. And that deconditioning can be happening to all of our patients currently in beds. And so I think the most exciting thing we're doing at the moment is we've got some artificial intelligence running in the background at the moment to identify the patients who come into our hospital who are most likely and most at risk of spending more than 21 days in the hospital, and trying to work to identify those patients immediately so that we can give them enough support in the first 21 hours to help get them back to the place that's best for them in the community. There's a whole raft of things that we are doing across the system to try and make sure that we build on the information sharing we've done this winter to improve everybody's experience of the healthcare system next winter.
Thank you, Mark. So just to summarise very briefly, obviously the key thing for us is what will be different in 22-23. So a key part of that is going to be supporting as a system the schemes that we know have worked well, and to build on those schemes to develop a really robust system-wide improvement plan that we can deliver across the system, and focuses on improving patient experience and outcomes, to optimise our use of digital solutions, as Mark has suggested, and really to take that planning approach. So I think probably planning now for next winter, which is just going to be a key thing. We know that we're not going to get away from the pressures of COVID immediately, so we will continue to plan and do our best. Thank you very much.
So Eve, just before I take Sarah Scott, who wants to come in, can I just thank you and your colleagues who have helped you with the presentation for the very clear and concise presentations. Can I also request you to go back to the Trust and thank them on behalf of this committee for all of the work that they put into producing this report and all the other papers in the pack of papers that we have. I think that the pack that we have today is like a Wikipedia of everything you need to know about Gloucestershire Hospitals Trust, Gloucestershire CCG, and all of the other trusts. I really think we sometimes take it for granted, but the hours and hours and thought that you guys must put into helping us to understand what's going on is incredible, and we're sincerely grateful for that. The only downside for you, is all of you, is that the more information you give us, the more questions we're going to ask you. But please don't let that put you off. So, Eve, if you can take that back to your colleagues. And I'm now going to invite Sarah Scott to say a few words before we take questions. Sarah.
Thanks, Andrew. All I wanted to say was that I think adult social care has played an equal part in the winter response. I think Eve has articulated that really, really well. And I hope it becomes really clear to you when you read the documents that we have really tried, and as we do every winter and all year round, to be an equal partner in the health and care system. So I think Chris was able to provide a really nice example about how we're seeking to divert people away from hospital where that's appropriate. But and we're really happy to take any questions that you might have.
Sarah, so over to you, members, both virtual members and members here with me in Shire Hall this morning. Questions? Dilys Barrow from Cheltenham, right down at the end of the table. Dilys.
Thank you. Thank you very much for that presentation. And I was particularly pleased to see how well health and social care are working together in this, because you are so much dependent on each other, I think. And, it's so good to have some of those stories and things. So thank you for that. Just a couple of things that struck me. In your report, the one Gloucestershire one, I think it's in connection with ambulance handover delays. It's mentioned that national guidance has reduced your flexibility to be able to respond to the various pressures, etc., that have been going on. I'm just wondering, what is this referring to? Is it just the COVID regulations, or have other rules and things come in that are actually preventing you work as well as you'd like to be working? That's one question I wanted to ask. And the other one's in connection to, this is adult social care. I think you've got government funding in order to encourage people to work in social care. And I think there's mention to payments that's made for people who are, employed for 6 months or more, etc. I'm just wondering, has it been successful, this scheme? And what about the long-term staff? Are they able to, have extra payments as well? Have I understood things, and does that make sense?
Well, if you've misunderstood them, then so have I. I think you put your questions really well. So who's going to take those questions, please?
I think there's a couple of us who probably need to respond. So the thing I think the presentation was referring to, I can recall the section you're talking about in the first part of your question, is referring to some national guidelines around ambulance handovers. Which I might invite Mark to just comment on as well as some of the regulations around COVID that have made it difficult for us to move people around our system. But Mark, do you want to comment specifically on handovers, and then I can pick up the other part?
Yes, so national guidance around ambulance handovers changed sometime early in February or late January, and about what we call cohorting areas. So one of the ways in which we have responded to the difficulty in getting patients off ambulances is to cohort patients in the emergency department. And those cohort areas have been staffed by paramedics from the ambulances, on the essential understanding that you can put 2, 3 or 4 patients in a cohort area with 1 or 2 crews, which releases 1, 2 and sometimes 3 ambulances, depending on how sick the patients are, back to the road, because we all want ambulances back on the road to be able to respond to emergency calls. We had a protocol for that, and Swast has what's called a halo, which is the person that sits in our emergency department and talks to the senior nurse and senior doctor in the emergency department to coordinate this and works out what's the best use of the resource that we have available to manage all of the risks that the people of Gloucestershire face. Guidance was changed to mean that Swast were not allowed to use their staff in those cohort areas. The reasoning behind it was probably the expectation that the hospital would then staff those cohort areas. The reality is that we've been unable to staff those cohort areas, or we wouldn't have used the Swast crews in the first place. However, and actually it's been counterproductive, because if we'd observed the letter of the law, you would have 3 or 4 ambulances queuing outside the hospital, when we could have got that down to 1 or 2 by using Swast paramedics. Now, we've been able to mitigate it to some extent by Swast making their bank staff, so paramedic staff, open to us. So we've been able to find paramedics to staff some of those cohort areas. And we've taken a common sense approach, which is whatever the national guidance is, it doesn't make sense to have 4 ambulances outside queuing when you could have 1 or 2. And that's made on a day-to-day basis. A decision is made by the senior clinicians who are managing both the ambulance queues and the emergency department, always on the basis of what's the least bad option in difficult circumstances to manage risk across both the hospital but also the community. So it's complex and difficult, but our approach is always to work together and to understand that you can't put all the risk in one part of the system, and we have to work together to manage the risk across the whole system. That being said, none of us would suggest that the current situation is anywhere near where we would like it to be.
And the second part.
Yes, I think I was going to invite my colleague Sarah Scott to respond on the second.
Sure.
I think Councillor Vines may have a question.
Okay, cheers, Stephen.
Thank you. Would you like me to answer the question in relation to the recruitment and retention payments to the adult social care workforce?
Yeah.
So we've had several different funding streams through to adult social care. I think we're now at 6 different funding streams that have come through during COVID. The last 2 have related to recruitment and retention payments specifically for adult social care staff. And these are staff that are employed in CQC registered social care settings. It could be a domiciliary care provider or a care home or a nursing home. So I think things have moved quickly, and so things might have changed since we actually wrote this report. But essentially, we agreed to use the first funding pot of 1.7 million to offer a recruitment and retention payment to staff in such care settings to reward people who've been in post for 6 months. We recognise that the care sector is under considerable strain, and that recruiting and retaining staff is a key issue for us. Indeed, it has been one of the things that have hampered our response during this winter period. So that payment has gone out. It amounted to around £185 per person for a full-time person before deductions. And then we were given a further pot of money, and that allowed us to make 2 further payments in this financial year. I think they're both going out in March rather than one in February and one in March, of around similar amounts to the same group of people. Now, when we put this out to our care market, because the idea was that we wanted to give out the money in the least bureaucratic way possible. And every time we give out money to our care providers, we have to have a grant agreement with them. So we have money for infection prevention control, we have money to support them undertaking vaccinations, we have money to support them undertaking additional COVID testing in their homes and their settings. And all this creates an administrative burden on the care providers. So we were really keen to do it in the easiest way possible for them, to get the money straight to the care workers' pockets in the easiest way possible. So we're issuing 2 further payments this month, probably around £185 each again. And also the CCG has offered a similar amount to enable a payment to happen further on in the summer as well. So we thought this was the easiest way to try and get the money to the pockets of the care workers. And if that answers the question.
It certainly does, thank you. So just check with Dilys, are you okay with that?
Yeah, it was the long. I just wondered about the long-term staff. Do they get anything? The people that have been there for many years.
So you only have to work 6 months. So it's 6 months or over. So if you've worked there for 10 years, you get a payment because you've worked in that particular care setting for 10 years. So it's at least 6 months you would get the payment. I think the other question was also around the longer term issue around fair rates of pay for the care sector. So members of the Adult Social Care Committee will be aware that we are awaiting further guidance around the care cap and the significant amount of Care Act reform that's coming in 2023. So we're going to carry out a cost of care exercise this summer. These funding pots are essentially a short-term fix to help sustain the care market until we can understand what the fair cost of care exercises will tell us. And then we're assuming there'll be some additional funding at some point to help us sustain the care market.
Okay, thanks, Sarah. So Councillor Hurst, question? Yep.
Thank you, Chair. A question for Sarah. Sarah, how successful have our retention schemes been? Is it noticeable that there's been a stop on people leaving the care sector?
I think at the moment it's a bit too early to say. So the first payment went out in January, the second payment, I think, last week. And at the moment, it's difficult to gain completely accurate data from the whole of the care sector around recruitment and retention because, of course, they're private businesses. So we do work quite closely with the Gloucestershire Care Providers Association, and we use them as our main route in. So they feed back quite a lot of intelligence, and indeed they did help us shape this recruitment and retention payment because we had some ideas and they came back and said, actually, no, it's not going to work. We recommend you do this. This is what our providers would find most helpful. So we do work in partnership with them, but at the moment it's too early to say whether this is actually having an impact or not.
Could you just ask a half question, please?
Half a question.
Half a question, because it's a follow-on. Can you tell me whether any care provider has in fact refused to take this payment?
So it was an offer to care providers. I think we had around 230 care providers that accepted the offer. I think that's the right number. I'll have to double check. But we need to remember that some care providers have multiple homes. So it doesn't necessarily mean that's the number of care homes or care providers. So I think what we'll be able to do is report back at a future scrutiny how many care payment, how many recipients we've had, because we will have that in the return. But there will be some that haven't taken up this offer. But then when we publicised the first payment, we went out again to publicise the second and third payment in case there were other providers that perhaps hadn't taken up the first offer that might want to take up the second and third. So we continue trying to find ways to promote the uptake.
Thank you, Sarah. But you'd think people would be biting our hands off to take the money, wouldn't you? But they're not.
There is an administrative burden associated with this for the provider as well, and that we can't get around that because it is public money that we're trying to distribute.
Sorry. Yeah, just before I take Helen, who's trying to get, is it Helen trying to get in? I can't quite see. Sarah, the other half question from me, is this scheme unique to Gloucestershire or is it implemented by other local authorities?
So all upper tier local authorities have been given access to the funding. I should just say David Drew's had his hand up for ever such a long time as well and is indicating. Everyone's had access to the funding, but I think the method of delivery and the schemes have differed because I think the idea is that you listen to your care providers and it's important to understand what's going to work for your local setting because sometimes the demands and the needs of the care sector differ between local authority areas. So that's why working with Gloucestershire Care Providers Association was really important.
Good news all round, it seems to me. So I'll be a gentleman and take Helen first. Is it Helen who's got her hand up? Helen, and then David Drew. Helen.
Thank you, Chairman. Helen Molyneux. I'm a district councillor from the Forest of Dean. Couple of things. When the discussion was about discharging patients from hospital to the most suitable setting, was it difficult to find care homes for those patients? And if places of care homes couldn't be found, was there enough care provided for them if they were at home? Nobody knows?
The end of the question. Sorry, I wasn't sure if Helen had finished. Yeah, okay.
So Helen, we're going to answer your question now, okay?
Thank you.
Okay.
Okay, so I think this is a combination of me and Eve. So I think, firstly, to reassure Helen, or perhaps it's not a reassurance, I'm not sure, but if a patient needs to go to a care home, we don't send them home instead. Unfortunately, our difficulties with accessing care homes, which have been for a whole variety of reasons that we can go into a bit more detail on, is what has contributed to the high level of people who are in our hospital beds that are often called delayed discharges or no criteria to reside and other such terminology, but obviously represent people who need to go on to a care setting and are still in our hospitals, perhaps not getting the optimal care that they need and the quality that we would aspire to. We've had some quite significant challenges, particularly recently with regards to infection prevention and control guidance, which have closed a significant number of settings in our county. It's something we're working really closely together on with obviously Sarah with her Director of Public Health hat on and public health colleagues and with the national team as well, actually, to see if we can work through some of the challenges we have with care settings being closed. So to give you a feel for the scale of the challenge, at one point last week of 53 nursing homes, I think was the number, only 2 were currently accepting patients because all the rest had closures and no capacity. So we're in a very, very difficult situation, and that is why we have the challenges we do around flow, in particular at this point, even though our kind of COVID pressures within the hospital have gone down, the incidence in the community is still high. And so that is causing a real challenge for our flow and our ability to access those home care settings. So I don't know, Eve, did you want to add anything to that?
I think the only thing that I would add to that is just the principles that we're absolutely committed to following as a system are the principles of home first, and to help the patient to go home with support. I think what I would just want to reference is the workforce challenges that we've had. Obviously, we've talked about social care, but in health, in terms of recruiting to GHC's Home First team. So we know that we're not quite where we would like to be in terms of being able to offer the number of reablement at home slots. So again, it's that wider workforce piece around recruitment and incentivisation, which then obviously, as Ellen said, leads to that longer delay in hospital and possibly needing to go out on a slightly different reablement pathway to enable the patient to leave hospital, but perhaps not to the place we would have ideally wanted them to go.
Great. So, Helen, we have a lot of people putting their hands up for questions. So, can you Helen, can you come back very briefly?
Very, very briefly. Several years ago, I remember a programme called Care. How did that work out? That was supposed to be recruitment and retention, and we never got figures for, or at least I never did, for how many were recruited and how many were retained. When I ring round the care homes in my area, I say, what do you need? They say, more staff. Thank you. Any ideas?
I was going to say, I don't have those figures. Sarah might have a better feel. I mean, we do have significant initiatives such as the one Sarah's already talked about around recruitment, retention, inspiring people to join the workforce. So I don't know, we might need to come back with figures.
Would you like me to answer that one, Ellen?
Yes.
Because it's an adult social care programme. So we do still have the Proud to Care scheme. I think one of the challenges is it's really difficult to attract people to care because of the salaries. And we've seen this really exacerbated during COVID, because people certainly, when society got back on its feet, we were seeing really big golden handshakes to go and work for the hospitality industry. We were seeing just a difference of 50 pence extra an hour adds up over the course of a week. Yes. Yeah. So the care sector has really struggled to compete with that, and that's why nationally the government gave the interim money around recruitment and retention bonuses, which we've been paying. But it is a significant issue, and Proud to Care was there to try and help make care be seen as more of a career rather than just a job. So we can provide an update. We do intermittently take updates to the Adult Social Care Scrutiny Committee, but I can include an update in our next set of papers to understand the work that we're doing. But unfortunately, it is really, really challenging because there are higher rates of pay in other sectors. Yeah. And so that's why it's important that we work with the Care Providers Association to understand, well, what would help them in terms of their recruitment and retention. So we're also working with the ICS Workforce Board to understand, well, how could we have a more collective approach to recruitment for these sort of roles at that sort of care worker level, to understand how we could make Gloucestershire look like a more attractive place to come and work.
That's a good point to end. That's a good point to end.
Yeah, thank you very much, Sarah.
And Helen, we can follow up on some of those issues with you after the meeting offline, if you'd like to. So I've got a long list here. I'll just rattle through it. David Drew, Kate Cody, Stephen Andrews opposite me here, and then Councillor Lisa Spivey. Okay, so David Drew first.
Thank you, Chair. Thank you for your good wishes. And can I add my own commendation to health and social care? I mean, this may not be the right place to ask this, but I'll ask it anyway. I mean, I've had a friend who's been on the virtual COVID ward for a week. He's off it now, thankfully. I just wonder who gets on the virtual ward. I mean, what support do they get? And in particular, if they're by themselves, I mean, do adult social care lock in to how they can help people in terms of food and the rest of it?
Take that, please.
So I can probably answer most of that. Although I think an interesting point is raised there about kind of food and the wider support, because if you really are suffering from COVID, as some of us know, it's very hard to kind of do anything for yourself, isn't it? But in terms of the virtual ward, and this is something we can be really proud of in Gloucestershire, so we were really at the forefront of setting up this model and setting it up at scale in the midst of the pandemic. And what was really unique in Gloucestershire is that all of our GPs, our whole of primary care, got behind this programme. So I think where you look at some of the other models across the country, it was done separately to GPs, or maybe just a small group of GPs working together, but every single one of our GP practices was part of the COVID virtual ward model. And that answers the question about how do people get into it. So if your GP has a concern about your COVID diagnosis, they've confirmed your diagnosis, they can refer you to the COVID virtual ward. And that sometimes may be as an alternative to referring you to a hospital if they were concerned about you. But it also is a level perhaps sort of below that, where they can refer you for additional support, and they can be reassured, you can be reassured. And what we also have done is we have within our primary care model, we have an organisation called GDoc, which is a collaborative of all our GP practices working together to form a kind of overarching provider GP organisation. And what GDoc are able to do on behalf of all the practices is ensure that cover is then through the weekends and 7 days a week. So the GP practices have that backup of the reassurance of the staff who are provided through GDoc to provide 7 day a week, all through cover for the COVID virtual ward, looking at the data that's coming through from the patients. So the patients are issued with virtual monitoring, so they can be checked all the time, and there's a point for them to come through to. And then obviously very clear escalation criteria should they need to be referred on. Now, I can't answer the last part about whether we specifically link in that wider support. I'd like to say yes, we do, but I don't know the details of that part of the model. It has been principally set up as a medical model to provide care for people through the course of COVID-19. Does that answer?
Hey, David, you okay with that?
It's a bit tricky when someone's
Yeah,
behind you,
no,
isn't
no,
it?
yeah, you haven't got the best seats. We'll make sure you get the better seats next time. Sorry. So David's giving you thumbs up. So I was surprised on your presentation, where I'm just looking at it, where you have what's worked well. You didn't list the virtual wards unless you called them something else on the list. And also the those small machines that you were giving out to patients. Oh, I can't pronounce it. Oximeters, they were so good. And at one point, my GP gave me them for, I think it was 10 days, give me one. And it just says going back all the time and all the rest of it. And as you said, something that you guys can be proud of, Gloucestershire can be proud of, and the people we represent are proud of, that you're doing such innovative work, particularly with, and I will get the name right again, yeah. Can you just in a second explain what those are for people who don't know what I'm talking about?
You want to take this one, Eve?
Yeah, so it's a probe that sits on your finger that essentially allows a clinician to tell how much oxygen is in your blood. So it's a really good marker of how well you're breathing and the impact that any infection that you've got, COVID, might have on your breathing. And obviously then that clinician, if you do start to feel more unwell or get worse, can actually wrap some care around you without, obviously dealing with this virtually. But as Ellen said, and you quite rightly pointed out, it's absolutely a piece of work that we're continuing to progress and look at the other specialties that we can involve with virtual ward as well. It's very much ongoing.
Sometimes in local authorities and sometimes in the health service, don't take this the wrong way, you're not too good at telling people what you're doing really well and what is innovative and what is cutting edge. And sometimes we listen to the things that aren't working quite so well, and we forget, to our cost, the things that you are doing well and which we should all be proud of and shouting about from the rooftops, because there really is some cracking work and cracking and innovative work being done in Gloucestershire by all of you. I apologise for my tendency to keep looking at the screen and forgetting the people to my right. Okay, so next I've got Kate Cody. Kate, what's your question, please?
Thank you, Chair. Thanks. It's interesting hearing about the guidance with the cohort areas, etc. Friend of mine, or recently a resident, her mother fell over was blown over actually in the wind, not during those storms, actually previous to that, at 2 o'clock in the afternoon, and she was lying on the road until 4:30. They couldn't move her because she'd broken her shoulder, and she was still in an ambulance at 11 o'clock at night, and she's in her late 80s, early 90s. So I'm just trying to understand if we've written to government about these guidelines, what else we can do, what assurances I can give that this sort of incident isn't the norm, and it's not a criticism of any kind on any staff. The ambulance doctors, etc., were brilliant, but it was this sort of queuing of ambulances, etc., etc. She actually spent the night in A&E, and that's a huge thing. She had a broken shoulder, as I said. So that's my question.
Okay, I think it's obviously a serious situation. Obviously, clearly, we're unable to comment on individual incidents, but who can pick those questions up, please?
So I think I'll start and then I'll hand over to Mark again. I mean, I think it picks up on some of what we talked about, obviously, previously. I mean, yes, you're right. We can't obviously pick up on the individual, but it does sound like a really dreadful situation, and I'm very sorry to hear of it. We are undoubtedly really challenged in our system, and not where we'd want to be. I think we've acknowledged that in the presentation and in the work we're doing. We certainly have picked up the baton in terms of raising the issues around ambulance services in particular, as well as seeing it as a whole problem. It's not just something that Swast are responsible for or the Hospitals Trust are responsible for. It's all of us working together. And of course, these things are really multifactorial. So you have a knock-on effect. If you have the issues we've talked about with the care homes earlier, and then you have lots of people who are delayed in your beds, it impacts on your ability to delay people out of your A&E department, which impacts on your queue, which impacts on your ambulance on the road. And the whole thing is a big circle that goes round, isn't it? And so that is the challenge that we face. But in terms of the very specific point about us raising the issues of ambulances and the challenges we referred to earlier in the guidelines, we have done that. And I don't know whether, Mark, you want to add anything specific, but I mean, that is certainly something we are part of in terms of the regional conversation and the national conversation.
Thank you, Ellen. And again, as Ellen said, just sorry to hear of that lady's poor experience. It's not something that any of us finds acceptable. But as Ellen's described, we are in a system, and if one part of the system is challenged, it affects the whole system. And it doesn't help anybody if we point fingers at an individual provider or an individual part of the system. We have to work together to fix this problem. As you can imagine, there are any number of national and regional calls and fora that we sit on and continue to raise these issues of concern, and in particular raise what I would like to think is a Gloucestershire position, which is that we're all in this together, because at times there is a bit of a national focus on the most visible symptoms. And ambulance handover delays is probably the most visible symptom. And, you know, because I'm speaking to a group of politicians, you can understand the impact that has on national politicians. But we can't fix ambulance handover delays unless we fix the problems that affect the whole system. And there isn't anything very good in any of this for anybody, whether you're working in the community or primary care, in the hospital, or trying to discharge patients. It's very, very difficult at the moment. And you know, we can rehearse the issues again, but you know, that's not acceptable to the people of Gloucestershire. We have to do better, and the assurance I can give is that the system is working as well as it has ever done, in my experience, together, and is seeking to address the problems. But that does mean sharing the risk across the whole of the system, and therefore there will be times when individual parts of the systems are particularly stressed, and unfortunately that will result in delays to care. And what we try to do is make sure that those delays to care are minimised wherever they are in the system, and that, of course, the most urgent people get seen and treated first. And particularly when there are queues, be they for elective care or for emergency care, that we know and understand what's going on with the people in those queues, so we can make sure that people don't fall through the cracks, and so that the most urgent people get treated. And also we try to be intelligent about our understanding of urgency. So you can be in chronic pain from let's say a bad hip, and on the one hand, that's not life-threatening and might not be considered urgent. But on the other hand, if you've been living in that pain for a number of years, certainly urgent to you. So we do try to take those sorts of things into account. Or if you have other distressing conditions which aren't life-threatening but are personally, emotionally, psychologically distressing, that is taken into account in particular in our prioritisation of our elective waiting lists.
Okay, does anybody else wish to come in? Sarah, has Sarah got anything to add? No, okay. If I can just go back to Kate. The Ambulance Trust do come to this meeting of Health Scrutiny, do come to our meetings. And offline, I'm going to see when they're due to come next. We think it might be the one after the next one. If that's the case, then given that we all have concerns, and certainly there's no finger pointing at all, I'm going to ask if they can come to our next meeting, which I think is in July. And you're very welcome to attend that, Councillor, as an observer. Okay.
Thank
So
you.
I still have, sorry, is that okay? I still have a long list, so people who want to ask questions. So Stephen Andrews opposite me here in Shireville.
Thank you, Chair. Keeping people out of the chain, the system, and I'm glad to see that the word system is starting to appear, is important. And if I can just ask you to comment upon a couple of things. I'm pleased to see that Rapid Response are now talking to the clinical desk and making sure that people don't go into the system, as it were, that don't need to, can go elsewhere. The next question, though, is are you expanding the falls programme that we've heard about, so that then, again, we can keep people at home who have just fallen, in inverted commas? The question which also goes along with that whole area of keeping people out of the system is over what's sometimes known as 111 misdirects. Are there any statistics that can be seen to show how many patients are being referred to 999 by 111 that actually don't end up getting taken to hospital and getting directed to another pathway? The argument being, of course, that perhaps there's either the need for a better clinical support in 111 or some other way, perhaps in fact using your rapid response teams so they can, 111 can refer the incident to the rapid response team or that sort of thing, just to keep people out of the chain and in their homes.
Okay, who's going to deal with that, please?
Yeah, I'll start. So, I mean, broadly, I'm going to say, first of all, you've absolutely hit the nail on the head about the work we're doing around avoiding that attendance in the first place. Is absolutely critical, isn't it? So we do have a comprehensive piece of work around our Falls programme and looking at adding the capacity to do more pickups and support people more quickly in the community. The sort of technical point you asked me, I don't have the data at my fingertips in terms of the 111 999 interaction, but that is absolutely something that we do look at. And we can see in the different, there's a lot of data that gets collected, and we've got out of hours as well, and the kind of interface between those things. And we are working as well with the region on a directory of services, which is also about how we direct people through those pathways, because more of these services operate on a bigger footprint as well. So by taking a lead, Gloucestershire is taking a lead there for the region, we can be more sort of in control, if you like, about the direction of people and the decisions that are taken. Because a significant proportion of it, although delivered by people, I suppose you would describe it, I'm thinking in sort of layperson's terms, a bit like an algorithm. So if this, then that, if this, then that. So if you can control the directory and make those choices clearer and more appropriate for people, then we can reduce the number of people who maybe don't get the absolute best direction in the first instance. But I mean, we could provide some of those figures, but I don't have them on me today.
Quick comeback?
No, that's fine, thank you very
Okay.
much. I think it would be useful to have a look at those figures sometime or other, perhaps particularly in the context of when the ambulance service are here, because they can perhaps usefully comment upon that side of things.
Yeah, yeah.
No, I
we're-
think
we're-
that's a good
we're happy
point
to
that
do
Stephen
that.
makes. Still, the list is getting longer all the time. Can members please keep their questions really quite snappy? So, Lisa Spivey, I think you took your hand down. Can I just clarify that? Do you have a
I don't
question?
think I had my hand up, but if I did, it was a mistake.
Sorry, I didn't catch that. You have a question? No. Okay.
No.
In that case, I'm going to move on to Helen Fenton. Helen, what's your question, please?
Oh, hi. Thanks, Councillor Gravels. I just wondered if we are quantifying the impact of these challenges at the moment. So by that, I mean the number of adverse outcomes as a result of these delays. So we heard earlier, Councillor Cody told us a story of someone who experienced an unacceptable, in Professor Mark's language, unacceptable delays and a long stay in an ambulance. So we've got temporary adverse outcomes like that, which include pain, distress. But we've also got permanent adverse outcomes, which includes deaths, injuries getting worse, the lack of timely treatment leading to perhaps chronic ill health or permanent disability, or very much delayed healing processes. So I wonder if we're capturing that data anywhere and what the figures are. Thank you.
So I'll start, but I'll ask Mark to comment as well in a moment. So yes, I mean, we do take all incidences of harm extremely seriously, of course, and we have a range of mechanisms for looking at the quality of our urgent and emergency care services across the piece. So that in part is external, so the reviews that partners such as the CQC would conduct across our urgent and emergency care services, looking at experience, quality, so on and so forth. But also our own internal reviews of performance and quality through our quality surveillance group, and we do conduct reviews of instances where there is a risk of harm. Now, we have talked ourselves about a more systematic approach to that and how we might introduce, I mean, it's across a number of different areas. So I think all the time you are balancing, and I think Prof. Petroni referred to this a little bit earlier, is the risk of in the urgent and emergency care system, but also in the elective care system and so on, and the cancer services as well. So we do conduct reviews across all of those and bring that information together to keep an assessment live of the quality we're providing across our services. But in terms of the specifics, I don't know if you'd like to comment a little bit more, Mark, on what we do within the hospital services as well.
Thanks, Ellen. So individual cases of harm are reviewed. We have well-established processes to do that. We've got a serious incident process. We've got a moderate harm process. And there's also the complaints process, all of which lead to investigations, which are reported up through various committees to the Trust Board. And there are summary processes that look at things like mortality. So, for example, there's a hospital mortality group that I chair, and that looks at particular areas of concern, but also looks at an external data set that assesses the hospital's performance in comparison with other hospitals in the country, provides external assurance or challenge around mortality associated, things that people worry about, sort of weekend, weekday mortality, et cetera, and those numbers continue to be well within national parameters. What we don't capture particularly well, I would suggest, is patient experience. So where the outcomes are good, but the delay is long, that's obviously an adverse patient experience, and we're not so good at capturing that. And I would also say that there is a huge piece of work to be done, and I'd look to Sarah and her team to pick this up, which is really a public health or population health piece of work, which is the long-term harm of 2 years of COVID, which has resulted in the stresses on all of our systems. And that would then, of course, bring in not just medical harm, which is relatively easy to measure, but harm such as harms to mental health, psychological well-being, what we call public mental health, huge burden on children's anxiety, distress, eating disorders is a huge problem. So in some ways, Councillor, you're asking the question about what's the long-term impact of COVID on our society, which is obviously a huge question. We need to break that down into individual pieces and understand it. And I don't really think that either within health or within care or within public health or within the academic world, people have got to grips with that yet. But that's likely to be the focus of a lot of work in due course, because it's obviously of huge importance to us and how we design and redesign and co-design systems and processes to manage health and well-being in what the next few years are going to be, and in terms of the resources that we as a country choose to make available for managing those. And I would suggest that the local authority, your public health department and health overview and scrutiny committee have huge parts to play in all of that conversation.
Helen, do you want to come back very quickly?
Sorry, I guess I was wondering whether my question was really about the long-term impact of COVID, or whether it was actually about the impact of the social care challenges that are having knock-on effects on A&E admissions and therefore ambulance waiting times, because these feel like things that we could and are doing things about, whereas COVID, well, we are doing things about COVID, of course, but that's sort of slightly more out of our control. But we do have control over things like the number of ambulances that the local ambulance service is able to provide. So I was really trying to look at whether we're capturing those kinds of impacts from those kinds of delays.
Yes, we are. And in some ways, I've been asking the same question myself. Can we collate them to get some sense of overall, the overall burden placed on, from my perspective, patients in the hospital or patients waiting to come into the hospital? That work is in its very early stages, but we'll no doubt do it in due course. I did see that Sarah was waving her hand, so I think she might want to comment on this too.
Sarah Scott. Sarah?
Hi, thank you. Just to say, following up on Mark's point, some of the work has been done already around trying to understand the impact on mental health, and particularly children's mental health. That has been presented to scrutiny committees. I think mainly the children's scrutiny committee, but Jo will be able to correct me. What we haven't done is brought it all together, because that is a truly enormous piece of work. We have already clocked the need to look at deaths and the impact of COVID on the number of deaths in our county, but we have to wait for the mortality data to be released, so there is quite a considerable lag. That work's been planned for the summer, so we are doing that. In terms of how you might identify the impact of adult social care, I don't think adult social care has had any greater impact than primary care, than Gloucestershire Health and Care, or the Acute Trust, or Swast. I think we are a system, and there's so many interdependencies that exist across our system. So yes, we've had a lot of care homes that are closed due to COVID, but equally there have been stresses and strains across our system, and it works in a cycle. So I think if we're going to look at that, we have to look at it in the main. I don't know how we would do that. We have had discussions at the Southwest level with the Association of Directors of Adult Social Services with the University of Bristol, trying to sort of use academic approach to try and understand the impact, but it is hugely complicated. And there is also an assumption that some of this work will be carried out nationally. So we can reflect and we can review on what we've done, and we quite regularly do that as a system. We try and understand whether some of the things we've introduced are actually working or not through the use of evaluation techniques. But at the moment, I don't know if there's a plan to truly bring together the collective impact of what we've done across the 2 years across the health and care system.
Okay, thanks, Sarah. Thanks, Professor Pietroni. Helen, I'm just so conscious that we have a lot of the people following you, and I don't want to deny them their opportunity.
I guess perhaps my question is, are we capturing the number of unacceptable patient experiences then?
I think that Mark picked that point up, and we can come back to that. And I'm certainly happy to continue that conversation offline with you, Mark. Okay, I do have so many other people on the list. Members, please keep your questions quite snappy. So the next one is Councillor Stefan Fifield. Stefan.
Thank you, Chair. Morning, everyone. I just wanted to say in the agenda pack that I really appreciated, particularly at the end, the content on the system-wide view and how that and the digital solutions and how that fits into the sustainability plan. I think that's really interesting. And I would love to actually wondered whether there's an allusion here to an improvement plan for these digital solutions, that it may be an item that we could look at in HOSC in the future. I think it's really important that we capture how technology is helping to improve decision making, data capturing, and actually services to people as well. I think I might just in terms of a question. ask how are these digital solutions playing into the sustainability plan, and how are you looking to improve them in the future? Because I noticed there are a few things that are in pilot and in development as well. Thank you.
Take that one, please.
Yeah, so I can. I mean, thank you for the feedback on the pack again. I feel like we're kind of thanks to the person behind me. That's appreciated, and I'm sure also I can't see whether Mark Hutchinson is still on the call, but I'm sure that he also appreciated the feedback. There has been a huge amount of work in the digital space, and I'm sure we would be happy to share a bit more detail on that at a later date. We are working on integrated systems, both in terms of patient information, but also how we monitor and manage our system collectively together. So integrated system flow dashboard is one of the things that we referenced in the pack, and showing how we're starting to collect more and more where we can kind of real-time data to tell us where patients are in our system, to tell us about the delays, where we need to sort of focus our attention to move things on. So it's very live, it's very much in development, and I think it is an exciting piece of work, and we've got some really good work going on, so we could share a bit more. Probably I think it would be better if we could put that, if that's okay with you, on a later agenda, maybe towards sort of September or something like that.
Pretty good. Yeah, really happy with that. Stefan, we're going to really have to move on. You okay with that, please? Thank you very much. The next one we have, if she's still here, and she is, I can see on the screen, Suzanne Williams. Suzanne, what's your question, please?
Good morning, everybody. Sorry, my question is very similar to Kate's situation, but I was personally involved with somebody who had an accident outside, away from the house, no vehicle access, nothing like that. And I'm a bit concerned that we were told by the 999 people not to move her. This was 5 o'clock in the evening. The light was going. It was getting drizzly and cold. So basically, we kind of ignored that information, and between us, we did manage to move her back to her property, which wasn't too far away, but not able to walk to it. And she eventually had an ambulance turn up her house 12 hours after the initial incident, which obviously not good at all. If we just left her, she probably wouldn't have been there quite so long. They probably downgraded her. I understand that. Excuse the cat poop again out my shoulder. But I just wonder, when they sort of say these things about don't move people, do they actually understand that it's not always possible just to leave somebody on the ground? You know, do they think about that idea? And I have to say, I'm going to have to sort of do this, and I have to go off quickly because I've had an emergency call from the food bank to go and deliver some food to somebody. So I'll have to go and leave my cat up there on his own. Thank you.
Okay. Again, we can't go into specifics, says Suzanne, but I'll see who can pick that up, if anybody.
I mean, I think probably it's something more. I'm not passing over the issue, which obviously is a really massive one, but where we've talked about needing to bring Swast into the conversation, because I think the point that the questioner is getting at is that point about the advice. And when we ask for somebody, when the advice is not to move somebody and they're in perhaps a situation where they would be at risk of hypothermia, how we kind of balance that advice against the response time. So I think that's probably something we'd need to ask our colleagues at Swast to respond to, unless anyone's got any further thoughts.
No, I would agree with that. And I think that one of the things that we're all starting to do is, as I said before, in terms of balancing risk, and in an ideal world, the advice would be not to move someone because an ambulance would be there in a short period of time. But when the likelihood of that happening, there may be other advice that is appropriate to give. But this is a Swast process, and they would be the people best placed to answer that question.
If I may, though, surely this is a 111 process, which is not necessarily Swast.
So, Suzanne, without mentioning names and addresses, can you email me with an outline of the situation you've just described and repeat your question? And I'm happy to take that up with the ambulance service myself to get that sort of clarification and advice. And then I'll circulate it to you and to everybody on this call, well, the members on this call. So I think it's a good question, and it's unfortunate we don't have anybody from Swast to answer it. But if you can just take the names out, the address, just put the general situation and your questions and concerns, because we all want to do the best, obviously, when we witness something like that. We'll get the advice of email the Chief Executive Swast, and then we'll circulate that to you and to everybody on this call, so that we're all the wiser. Are you okay to do that, please?
Yeah,
And
thank you, Uncle.
yeah, you've got a really busy cat behind you, by the way. It's really
Could I just make, sorry, could I just chip in and make our plea that I think we quite often make around our patient advice and liaison service, our PALS
sure, absolutely.
service. Becky can provide
We had a
details
session
of
on
that.
PALS last time, and if you look at the minutes of the last meeting, all the references to PALS are in there, along with all the other contact details for the health service. Just so keen to crack on. Susan Williams, my neighbour, my county councillor neighbour. So, Susan, are you on the phone? Are you on the call?
Chair, might I just add, you might want, so 999 is run by Swast, 111 is a separate provider.
Yeah, sure.
And both will be giving similar advice to people over the telephone. So you just need to be clear, either approach both or one, depending on which is appropriate.
No, sure, it's good advice. Thank you. Sue Williams, my, like I said, my county council neighbour just up the road in Bisley. So you still on the call?
Yeah, thank you, Chair. I think part of my question has already been answered, and the rest I can take offline, because I'm very aware that you have many hands being raised. So we can do it via email. Thank you.
That's really helpful. Does anybody wish to add anything to that? No. So I think the last question, and he's going to make it really snappy, is Councillor Padilla from Gloucester, like me from Gloucester. Ray, short question.
Thank you, Chair. Firstly, thank you for the reports. Very informative, clear, and concise. I understand that the aims are to prevent hospital admissions and initiate discharges within 72 hours. Just out of interest, have you got statistics around failed discharges? And failed discharges, as many of us know, are those which have to be readmitted within 48 hours, primarily because sufficient measures at a discharge destination were not put in place prior to them leaving the hospital. And my second point is, apart from Age UK, which is present in ED, do we have other voluntary organizations which can help as discharge support coordinators to prevent any more failed discharges in the future? Thank you.
Yeah, so it's a really, really good question. So I'll ask Eve to respond in part as well. So we do monitor readmissions. So that's when somebody has gone home and then obviously come back to hospital again within a certain time period. And we do also have a number of partners that we work with. So it isn't just, I think, did you mention Age UK? We also work with the British Red Cross and some other partners around supporting discharge. But it is also something that we've identified ourselves as an area we want to focus on in more depth. So we're doing a particular project now looking at people, particularly where they maybe only need one visit a day as a recommended support, as to how we could get voluntary sector partners more engaged there. And also thinking about the wraparound for all people who are going home where we can, to start to think about how we're linking them back into their local community, because we know that that's really important. But Eve, did you want to add anything to that?
Thanks, Helen. Just a comment around the readmissions piece. So yes, absolutely, failed discharge or readmission is monitored. I think I'd be keen that we break that down into kind of two criteria. So we review a failed discharge from the point of view of have we then failed to put a service in place, but also if we're truly following the principles of home first and trying to get people back to their own homes with support, that a percentage of those patients will go home and then either require readmission or a percentage of other services to support. And that doesn't necessarily lead to that discharge being failed, perhaps. It will help indicate whether we think that there's an additional layer of support that's required to keep the patient at home, or whether that isn't the right thing for them. But our absolute commitment as a system is to trying to get patients home with the support they need and re-able them at home. But in doing that, we have to accept that there are a number of patients that for whatever reason may not achieve that. It's how we then capture that, how we quickly mobilise around the patient and how we provide the services to support them into the right pathway. So yes, absolutely.
Okay. I know you're eager to take over your piece, but is it a quick question?
Quick question.
Okay.
Can I fire away?
Yeah, sure.
Thank you. Last week, Point West told me that there were 2 new units in Gloucestershire. 1 unit at Gloucester Royal and 1 unit at Cheltenham General, which were quite groundbreaking in the speed that patients were attended to. You want to comment about those 2 new units?
I was going to say, I'm assuming that you're referring to same day emergency care. So I think, Simon, would you like to talk about that?
Yeah, so one of them is the same day emergency care unit at GRH, which enables patients to be referred direct from a GP into the hospital and turn around quicker, so avoids an ED attendance and often can avoid an admission. And the second one was an enlarged radiology unit at CGH. Yeah. So both really, valuable assets that increases our capacity and turns around patients more quickly.
Will accelerate patient throughput, will it?
Yeah, so both of them, yeah. So the radiology unit enables patients to be diagnosed quicker and get them on the right pathway quicker, so cancer patients and other conditions. But the same day emergency care is a real asset. So that's the one that will, some of the conversations we've just been talking about, that's the ones that will really have an impact. And it's part of the strategic site investment, so the 40 million scheme that I've come here and talked about a few times. That's the first element of that scheme delivering, really.
Okay, so if I can just wrap up this this part of the agenda. So both of you, thank you very much for the snappy presentation. Always appreciate a snappy presentation. But as you can see, that's given us so much time for members' questions, and everybody has had the opportunity to ask questions and come back with supplementary questions. Particularly pleased that other members have picked up the worth and the huge amount of knowledge and schemes in the information pack that you drew up. Please take that back to the team and thank them for all the work. I described it when I started to speak as a Wikipedia of everything you wanted to know about the Gloucestershire Hospitals Trust and the winter programme. So we're going to plough straight on. We're not going to take a break, but if anybody needs to leave now, please feel free to leave. And thanks, members, virtual and here in Shire Hall, for your questions and your patience. And to everybody who's answered questions, whether they're from the Hospitals Trust or whatever trust, thank you for your courtesy to our hospital and adult social care members. So with that, quick grasp of breath, and over to my colleague, Councillor Stephen Hurst.
Really?
Yeah.
Joe, can I have a clue, please?
Sorry, we're now on to item 6,
sorry.
Stephen. Okay, item 6, and Siobhan's going to do a little brief overview of the report that you've got in your paper, and then we're going to take questions. So I think it's straight over to Siobhan, Stephen.
Siobhan, yes.
Yep, thank you.
Siobhan Farmer. Who is going to talk to us about the Gloucestershire Child Measurement Programme regarding obesity, weight management and things of that nature. Thank you, Siobhan.
Thank you, Councillor. So, colleagues, you've got the full report in your pack. We did also have a short slideshow, but rather than show the slideshow, I'll just talk you through the content. It won't be a particularly long report, as you can see from the detail. I think the important thing today is that we know that you've previously expressed at the scrutiny committees, both in HOSC and then adult scrutiny, around the rising levels of obesity and the impact on young people. And we were waiting for the results of the National Child Weighing and Measuring Programme, which is an annual survey whereby the public health nursing team will go into schools and weigh and measure children and then report back on those surveys. So today's report gives you an update on that and will highlight the increase that we've seen in those figures, and we can speculate on why that might be. We're also going to talk very briefly about the investment that we've agreed as a council and what we're going to do with that for the coming years to tackle this issue. And then also just highlight a couple of the sort of wider things that we'll still need to maintain a focus on if we're ever going to address the problem holistically. So if I move on then to the National Child Weighing and Measuring Programme. So it's really important to do this annual survey because obesity does matter. all colleagues, councillors will know that it not only, especially when acquired when young, leads to a greater increased risk of health conditions such as asthma, type 2 diabetes, etc., but also has a huge impact on mental health and includes challenges around bullying and stigma, etc. So it is definitely something we need to address. The 2018-19 survey happened as normal, but clearly 2019-20 was affected by the pandemic. So because it usually happens in the back end of the school year. So our 2019-20 data isn't really good enough to share, which is why that's not in this report. And we're really only looking at the 2020/2021 data. The national guidance, because schools were still very much impacted by COVID in that year, was to only do a sample of 10%, a representative sample of the schools. So we did manage that for year 6, but that does mean that you'll see in the report that the figures are starred. So anywhere where we've achieved less than an 85% weighing and measuring total, we've starred that just to say the data's okay, but it does need to be interpreted with some caution because obviously we've missed quite a significant sample of the population out. However, the reception data that we did in 2021, we actually got 98% of children weighed and measured, so it's really accurate data. So if nothing else, we do have a good idea about what's happening with the reception children and an indication of what's happening in the year 6s. So the challenge, obviously, from the report, as you'll see, is that obesity rates have increased both nationally and locally in reception and in year 6. And there's 2 categories detailed in the report, one of obesity and one of severe obesity. To give you the reception figures, essentially we're talking that from 2019, there was around 592 children affected by obesity. And in 2021, that's gone up to 884. So it's almost a 50% increase on that first year's data. And of those 884, around a quarter of them, 260, have severe obesity. So that is the level at which those health conditions are much more likely. And the other thing just to mention is that there's a big health inequalities dimension to this. So a few years ago, we were looking at between the most affluent areas of the county and the least affluent areas, there was a gap of 4.2 percentage points. That's actually increased in the latest data now to 5.3 percentage points. So our gap between our most affluent and our least affluent communities is getting wider around this issue. And then clearly there's other variations within the data as well, such as obesity does tend to be more common in boys than girls at that age, and it does vary across the districts. Gloucester City is the highest district, but again, that's probably tied to that deprivation challenge. All of that gives us a really very conservative estimate of around 25,000 children in the county who have obesity. Which is, really quite a challenge for us to work with. And we're not going to address that through single weight management programs. I will talk about that because it's an important part of it. But actually what's really important is our wider initiatives that tackle wider determinants of health. So things like food environment, physical activity programs, things like We Can Move, thinking about food poverty, and clearly with the challenges recently around the rise in fuel costs means some families are faced with difficult choices around eating or heating, and those eating choices may not therefore be the best because of that financial pressure. So it's not a simple issue. I think everybody says losing weight is easy or being a healthy weight is easy. It's an equation between energy in versus energy out, and the fact is that it isn't. It's way more complex than that, and so if you're trying to heat your house, you may not be able to feed your children as well. So it's absolutely a structural issue around all of the challenges our communities face. So we need to keep working at that very preventative end and doing universal activities to ensure that people understand how to eat healthily, how to take physical activity and where to take those opportunities. But then we do need a more targeted offer. So we've had a more targeted offer in the recent years. It started in January 2020. It's called Busybodies, or BZ Bodies as it's spelt in the report. And that's an initiative for young people and their families recognising that it needs to be a family approach to tackling obesity in children. That pilot ran, well, it was supposed to run, as I say, in January, but very soon had to move to a digital offer because of the pandemic, and started again face-to-face in September 2021, sorry. The report details the outcomes from 3 pilots, 2 in Gloucester City and 1 in the Forest of Dean. You can see the outcomes are incredibly positive for those young people, and we're running more sessions now, and we'll keep collecting that data. We're having an independent evaluation by the University of Teesside to make sure that we understand the programme and its successes so that we can roll it out further. And we were delighted that in the budget in February at full council, the additional money for sustaining this service was approved, so we now have the ability to commission a programme to tackle overweight in children for I think it's the following 4 years, which is a great news. But just to temper your delight at that, it will only be able to work with approximately 560 families a year, so it's not huge numbers, unfortunately. We just would need much more investment to be able to extend that further, so that's something we'll keep looking at. The final thing then to say is that there are, as I say, those wider issues. We do need that digital weight management offer alongside it, and we do need to continue to help to engage families to understand that they can tackle weight themselves with their children. And we'll continue to work on wider aspects of that whole systems approach, and with NHSEI and CCG colleagues to make sure that we've got those routes into that severe obesity pathway. Around 10 families a year will access the Tier 3 service, the high-level service at Bristol, for more intensive care in a hospital setting. So we do need to make sure that that pathway is aligned as well. So I think that's all I needed to say, councillors. Happy to take questions. Hopefully that's helpful.
Tim, over to you.
Thank you, Mr. Chairman. I couldn't hear anything there, but I thought I'd gone deaf, but perhaps it wasn't at my end. But hello, hope you can all hear me. And good morning.
Yes. Yeah.
I wanted to, first of all, thank Siobhan for the report, and thank the public health team for it. I think particularly Sue Weaver has done a great deal of work on this, and I met her a few times. We're particularly pleased that we're able to secure the funding, as mentioned at our recent budget meeting. I think when I was originally given this job, I think I identified doing more on childhood obesity. It's something we really needed to do. So though we still, as you can see from the report, got quite a long way to go, I think this is a significant moment. And I think you can see that the pilots have been successful. So I just wanted to commend what's been done and to hope you will recognise that work. And clearly I will do all I can to secure further additional funding going forward.
Have Kate Cody who wants to ask a question. Kate.
Thanks, Chair. Yeah, thanks, Siobhan, for the report and update. Just to say that one of the primary schools in my division, they actually run a mile a day at school. Every pupil in the school, and they have a sort of circuit of the playground, and the teachers do it as well. And they all run round and make sure they've actually run for a mile a day. And I just wondered if that's the sort of thing that could be rolled out to other schools as a really good example. And also give a shout out to the school streets and anything anybody can do to promote that, because obviously that's active travel and trying to encourage children to walk and cycle safely to school as well. And that's working really well as well. Thank you.
Oh, is that Fiona?
Oh.
I know it sounds stupid, is that? I'm in a meeting actually.
Councillor Tracy, can
you just be quiet for a minute, please?
Could you just mute your microphone, Councillor Tracy?
Thanks, Councillor Cody. Yes, you're absolutely right. Some schools are using the Daily Mile as their, a great way to encourage regular physical activity. I think it predates me. I joined about 6 weeks before the pandemic, but my understanding is that the Daily Mile was promoted to all schools in Gloucestershire prior to me joining. I think it might be a good idea now that COVID is easing a little, that we have another look and see how many schools are still taking part in that. So that's something we can have a look at. And you're absolutely right that it is much more than just in the in-school initiatives. It's about how we travel to and from school. So we do work closely with the environment team and are working around things like safer cycling routes, pedestrian routes, etc. And some of the Levelling Up Fund, for example, got a Bishop's cycling way in Bishop's Cleeve that will connect the corridor between Gloucester and Cheltenham, which again is, can be used by secondary school pupils to get to and from school. So we are making sure that there's those wider initiatives are supported by the public health team. Thanks.
Steve Robinson. Councillor Stephen Robinson.
Thank you very much, Stephen. Thank you. Yeah, I was just wondering how difficult it must be within the school for parents to, when a child is identified, for this sort of contact with the parent, and what is being sort of done to ease that in. Could somebody tell me, how that happens?
Yeah, it's a really good question, and I think that the challenge is that the programme we've set up doesn't have capacity to support every young person that would be identified through the weighing and measuring programme. So we'd have to target it to those who are at the higher end of the obesity measurement scale. However, that's being done currently through working between the public health nurses and the schools, so that there's a gentle conversation had with the parents so that they know there's an option available to them to take part in this programme. So it's quite targeted at the moment under the pilot. We will need to look more carefully at how we do that as we move to a more universal offer, and think very carefully about those sensitivities. It's not an easy thing to be told. The National Weighing and Measuring Programme has always been quite controversial in that respect, in that when parents do receive the letters, we know it can be quite impactful and very difficult for parents to read. But there's been a lot of work about how that's phrased, and then the support services that are put in place and people are signposted to through the letters has massively improved. But yes, for this particular programme, there's a sort of one-on-one conversation at the moment to handle those sensitivities. Thanks.
Okay.
Thank you.
Now we have David Drew.
Thank you, Stephen. Siobhan, with the growth of home education, what access are you getting to children who are home educated to carry out any sort of measurement?
Thanks. So at the moment, the National Child Measuring Programme is a school-based programme, so there will always be a small cohort of children that we miss. The access would be via, when they're younger, through the the health visiting service and the public health nursing service, who would be doing those regular checkups. And clearly, our primary care colleagues are massively play into that, because that will be the main contact with those children from a health perspective as they go through their childhood and into adulthood. Sadly, I think we can always improve more about how we have contact with children who are homeschooled. Something we probably need to think further about moving forward. Thanks.
Thank you, Yvonne. Stephen Andrews. No. Lisa Spivey.
God, I don't actually even know where to start with this. I find it such a such a sad situation, I have to say. And I find the statistics quite shocking. And when you say very obese, I mean, God, we're not just talking about a bit overweight here then. If we're talking about obesity and very obese, the long-term impacts for those children must be quite drastically affected by this, because I know that if you are overweight, as you start puberty, the likelihood is you will be an overweight adult. So that is really, really shocking. From my perspective, it's pretty harsh. I know, but I listen to the likes of Jack Monroe, who's a fantastic advocate for eating well on a very limited budget. There are a number of resources and people out there, who are very active, who come from incredibly deprived backgrounds as well. But this is about a choice. And these are parents who are not feeding their children correctly. I mean, let's be really honest. And, we get the eating or heating, but, I don't know what's happening. But, I would hope that the vast majority of 10 and 11-year-olds are still being fed by their parents. I know that there will be situations where there are children who are not from those supportive families, and who are left to fend for themselves. And, I'm sure, my 11-year-old daughter would rather have a packet of Haribos and 10 Whisper bars than an apple. But, I really do think that that we need to be really targeting the parents and get that education in there now, because these are the people who are feeding the children essentially the wrong things. There's and I know that there's like supermarkets, like at Tesco's, you can go in and help yourself to fruit, for example. And like I say, I think there are lots of things, but it's about, people are just making the wrong choices, and the impacts on these children. I almost feel that it's a form of child abuse. I feel so strongly about this. I just think it's absolutely dire. And I'm not even sure what my question is or point is, but it's so distressing to hear these statistics. If there's anything that we can do, and I think it must be targeting the parents and getting them to make those right choices for their children. Otherwise, we're just creating so many problems and health issues in the long term. It's really distressing.
Thank you, Lisa. I think Siobhan would like to say a few words in answer to your question. Thank you.
Yeah, and I don't want to take away from the fact that, in some ways it could be perceived as a choice, but I think we have to recognise that choices are easier for some parts of our communities than others. So those of us who, those families that have two parents bringing in an income and have extra childcare may find it easier than somebody who's working 3 jobs and isn't always able to prepare a meal from scratch that's healthy. And now I don't want that to sound like that's excuses, but I think it's a reality of the situation we're in, and that's why we need to recognise that some families need this extra targeted support from the programme we've got. But in addition, Lisa is right. It is it's a whole society issue. It is about much more than just the children themselves. And the council has just agreed to the commissioning of the family hubs model. So that will be it's a sort of a revamp of the children's centre model, and that will be around putting hubs in our communities that will work with families, especially with very young children. So that will be the kind of way that we can target all families earlier on and make sure that those messages and help and support to understand what those choices are and how they might make them more easy for themselves can be supported. And clearly we do an awful lot of work through schools and the curriculum, etc. But ultimately this is about more than just being able to give people vouchers for fruit. There has to be much wider support around that and a whole system change. Things like you'll know that junk food adverts have been removed, for example, and talk about tax on sugary drinks and those kind of macro policies that will also need to support these changes.
Thanks. Thank you, Siobhan. Now we've got Phyllis, followed by Linda. Phyllis?
Thank you, Chair. Yes, an interesting programme that you've got underway. A couple of things I wanted to ask about. I'd like to ask about the position of parental consent in all this. Is this something that sort of happens to all children? I've certainly had contact with one mother who very much didn't want her child to be measured, felt this was a detrimental thing for their development. So I'd like to ask about that. You say you've got a pioneering structural resilience weight management offer. I just wondered what that was about, if you could tell us any more about that. And the other thing that comes to mind is, of course, I'm a representative from Cheltenham, and we've got the No Child Left Behind scheme underway, which covers all sorts of things, including healthy eating and various other things to help keep children healthy. I'm wondering how much you work together on this sort of thing. Thank you.
Yeah, so was the first question about consent to take part in the weighing and measurement programme, is that right? As opposed to the offer of weight management support, yes. So in terms of weighing and measuring, no child would be weighed and measured without their parents' consent. It is something that they can opt out of. They will get a letter home. So yes, there's no need to consent if the parents don't wish for that to happen. I think the challenge is that it's always been a very controversial programme in that sense. Do we set children up to weigh and measure themselves and think about their weight? But it's a really important part of understanding the current trends in obesity in our young people, and it's the only way we can do it in a way that gives us a true representation by weighing and measuring as many as possible rather than singling out a few children. So that's absolutely been thought about, and indeed we had I think about 15 years where we didn't weigh and measure children, and we lost that ability to understand where the trends were and where we should target and support people. So that's that part of the question. The second bit about the pioneering structural resilience weight management offer, Tim did highlight that it was Sue that wrote the report. I did suggest that might be a challenging statement. We have explained it in the paper, and it is very much about that fact that there are more things that affect obesity than just what you eat. So it's about those barriers to be able to exercise, or perhaps they need a family support worker to work with them to understand how they can, budget better for food, for example, or think about those childcare issues and what they, give the school or the nursery, what they take to school, etc., with them. So it's very much about those different barriers that might stop people, rather than, as I say, just the food that you put on somebody's plate. So that explains that part of it. Was there a third question at the end? Sorry.
About working with No Child Left Behind.
Thank you. Sorry.
Things they're doing there.
Yes, and so clearly we work very closely with the district colleagues, but I think again with the pandemic we need to make sure that we're reinvigorating those links and ensuring that things are as joined up as possible. When we've got such limited resources and such a big challenge to tackle, we need to reduce duplication wherever possible, and things like No Child Left Behind will absolutely be a key part, but it's a huge jigsaw, as you can see, in terms of the things we've got to do to address the issue. Thank you.
A number of things here, really. The first thing is that I'm not sure that this is a subject that gets the attention it deserves. If we don't get this right, this is about the future of our NHS, because we will never, ever be able to resource this truck that is coming at us really, really fast. And the other thing that hasn't been mentioned here at all is that everybody blames COVID for everything. The truth is, because I work in a lot of the schools in Matson and Tuffley, so I deal with these children every single day, and I'm interested in their reading. So I asked the question in my normal bullying way about how many hours they're going to spend on their computers and playing computer games, and the results are shocking, and that's what's happening. Some of them will spend an entire weekend, from the moment they leave school on Friday night until they come back on Monday morning, will not leave their homes, and that's why obesity is becoming a huge problem. We've got these schemes which sound marvellous, the results are good, but they can only, it's the tip of the iceberg. You talked about a figure of 25,000 children. So we have to do something that's built into the DNA of everything we do, and it has to be a wholesale approach. You mentioned earlier on the Mung Run. The good news is that is alive and well in a lot of schools, and it's a really fantastic example of something simple that doesn't cost any money, can just be built into the infrastructure. So we have to build back moving more, which was something we talked about before, and simple things. Lisa was horrified by parental choices, but the truth is that a lot of the parents of the children that I see have never been taught how to cook. They are a generation who were also badly fed, and so that education is just not there. We've stripped out cooking in all of our schools. It's ironic, isn't it? It's only in some of the grammar schools that they are still. Last night I went to an event and there was a pupil from Marling who was winning a prize for cookery because they do cooking at Marling, but it was the only school that did it. So we're not doing the basics. This programme is not sustainable. How much does it cost per child for one of these programmes, per family?
I'd have to do the calculations, but
It's going to be huge, isn't it? When you throw it up, it's not doable. So we've got to get back to basics and start doing things properly and go back to more exercise, more joining football teams, more just generally doing the normal stuff, which then means you have a sea change. And I think as a council, it behoves us to really think about how we work with schools and communities, and rather than tinkering around at the edges and, you know, sort of schemes that look fantastic but actually are not sustainable because they just cost too much money. And what we can do to work together with schools, because obviously you've picked up the baton, but we've got to help you. It's huge and it's got to be solved now. And 50 families just isn't going to do it, or 500 families. And how could we use that money better? Because food isn't always a problem, but it's about the time, the understanding. There's a lot of food in Max and people are very generous. You know, there's plenty of food in the food banks, but it's helping people to use that food intelligently so their children do better. But it's calories in and calories out. And if they're not moving, you're not going to solve it. And that's just going to be something they do. You know, children shouldn't have to think about it. They shouldn't be weighing themselves and measuring. Children run, they move. That's what children do. And they're just not doing it anymore. So how do we break that cycle? And that's, I think, the big challenge. But, you know, the work you're doing is fantastic. But this is going to be top of our agenda, not a thing that we trot out periodically. You know, it's about every single child, it's about their future, and it's about the quality of life. I see already the children who are ashamed, they can't take part, they just aren't, you know, enjoying full education or full socialising.
thank you. And just to respond, I completely agree. It's an incredibly complex issue, and we're hardly scratching the surface with this service. But I think it's about both. So I think we still need the service.
Yes.
And I appreciate you saying there's an opportunity cost of that. We could be spending that money on something else, but we are doing other things as well. So, you know, the Daily Mile in schools is one example. There are a vast range of other things that we are working on. And also it's a priority for the Health and Wellbeing Board. So it's regularly reviewed by that board, and all partners across the county sit on that. So it is a key issue. It's one of the 7 key priorities. But yeah, the more we can do locally, the better. But we're also a little bit beholden to the government strategy as well, and the resource that we get to fund this. We have obviously a limited budget for which we need to prioritise a number of other things within that. So the more money we can put in towards these initiatives, that would be great. So it might be good if we could divert some of the sort of downstream money into some of the prevention money in order to stop the NHS problem in the longer term. But clearly that's something we've only got small control of locally. Thanks.
Kate?
Thank you, Chair. Yeah, can I just start by just asking who the woman is who spoke just before Siobhan then, because we can't see your names. It's excellent what she said. It just says Maxwell Young on the screen, and I know that's not any of you. So could I have the name and role of the woman there? Just very briefly, a couple of things to add. From my thoughts on this, I think we need to get children into sport or nature. We've got a local nature reserve here. We've got an education officer. We need to get the children and their families involved in that. And not everybody's into going out and whatever. I used to drag my daughter up Malvern Hills to much complaints, but she now walks and does those sorts of things. So, and if you're not into nature, perhaps sport. We need to really, really see what we can do extracurricular and help in these areas. One point I'd like to make about food bank, it really worries me quite often, and I know there's an issue with perishables and things like that, but quite often on the list of food that food bank are asking for is things like sponge puddings and biscuits. And I know that it's a massive issue and we can't just give everybody healthy food and expect them to eat it if they've never done that. But I think who writes the list of what the sorts of food coming into food banks is. And the third thing to mention, which is coming up later, but maybe this is really good news from trading standards, that that from April 22 there's going to be this requirement to display the calorific value of food, and also that there's going to be restrictions about how and where we can promote, or large businesses can promote food that's high in fat, salt, sugar, etc. So entrances, checkouts, 2-for-1 offers and things like that. So that's helpful, I think. But I just think more, what can we do as counsellors to really help engage extracurricular for children, and cookery, actually. Really good point there. I learned these skills at school, and you know, they're not doing that now, and it's really sad. So how can we help with possible extracurricular, before, after school clubs, those sorts of things, with sport, nature and nutrition? Thank you.
Thanks, Councillor Cody. I think there's a number of strands to that, but just to mention briefly, there are initiatives such as the Holiday Activity Fund that's been running, which has a range of different activities to take part in, and many of those are run by the voluntary and community sector, so they're key partners in this as well, because clearly they're good places to signpost families and children to take part in those things. I believe our Director of Public Health just messaged me and said she'd like to come in, so I don't know if I can invite Sarah to speak. Is that okay? Thank you.
Thank you. I think the lady you referred to are either Lisa, who is from here 2 left to you, or Dilys down here.
I think it might have been Linda, actually. I think it was. We were talking, Kate, about the discussion about exercise and more movement.
Well, I can't see at the moment.
Don't worry, you'll be able to see on the recording. The recording will give names of everyone, but I can help you if you want to connect after the meeting. Okay.
Thank you. I appreciate that. Thank you.
Back to you, Siobhan. Did you want to bring Sarah in? Yes, Sarah.
Thank you. Sorry, it's really difficult to see because we're obviously dialing in. I think the point made, I think it was by Linda earlier on. I just wanted to come back on that because I think you made some really good points, and I think the danger of bringing a report about something very specific, which is the change in the obesity numbers and the specialist service we've commissioned to deal with part of that, is that we miss out an awful lot of context. So the Health and Wellbeing Board has had a priority to tackle, to promote healthy weight and tackle obesity for the last 9 years. I think all the evidence tells us this is hugely complicated. It is more complicated than energy in and energy out. It depends on your knowledge and skills in relation to food. It depends on how much exercise you get. It depends on the availability of food where you live, and we know we have some food deserts in Gloucestershire. Indeed, there is a briefing at the end of this, of the pack, on some of the work we're doing around food availability and sustainability in Gloucestershire. So I think it's just important to see that in context. I do believe it's very important that we have this, what we call Tier 2 specialist service for obese and overweight children, because essentially if we don't, we have a universal offer, which is the Daily Mile, and the CCG and Public Health work together for a number of years to promote that with our schools, and we had very high take up before COVID. But if we didn't have this service, there is nothing then until you get to bariatric surgery for children, which I think is a completely obscene thing to put a child through. But there are very few cases where that is necessary because a child is so obese. So we needed something in the middle, and we haven't had this service in Gloucestershire. And I'm grateful to the CCG who funded the pilot. And as Siobhan said, the full council and the county council approved the funding for this service recurrently last month. So I think that's a really positive step. But there are lots of other things that are contributing to obesity, and we have got a strategy that helps define that. For example, one of the other priorities for the Health and Wellbeing Board is around promoting levels of physical activity, and we work with an organisation and we have a project called We Can Move, which is around really trying to focus our efforts around improving levels of physical activity in certain parts of the county. So I'm not saying it's a perfect solution at all. We absolutely do not have enough funding for this, without a shadow of a doubt, but obesity is extremely complex to tackle and will take years, I think, because we're trying to undo behaviours, we're trying to almost teach new skills that perhaps people weren't taught during their own childhood. So it is hugely complicated. I do think this is a positive development, but it probably almost certainly isn't enough. Over to you, Chair.
Kate, your hand's still up. do you want to say?
Just very briefly, the food bank thing that I mentioned, do we have any influence on that? Who decides what list is going to be the products that people are asking for donations for?
Kate, I think it's Sarah here. I think it is the food bank. I think the other thing I would say is that in terms of the advice we give around healthy eating, one sponge pudding per family per week is really not a problem. It's if you're eating them every day. It's about that balance, isn't it? And I think there is something around we can't control what the food bank ask for, and we don't know whether they actually get what they ask for. There is something about balance there, isn't there, in your diet, and having a smaller amount of sugar and saturated fat is what the current advice is.
Okay.
Have you ever seen a microphone bounce across the floor? The Thrustle Trust is a mover in the organisation of food banks, isn't it? Perhaps it may be an idea to contact them about recommended lists.
There's also a group working across the county on a food strategy currently, so I'm sure they'll be taking into account the food bank dimension as part of that. I'll feed that back to them.
I think we're almost done there then, Stephen.
I think we are, Jo.
Thank you,
Yes.
Siobhan, and
Yes.
thank you, Sarah. And I think it's back to Councillor Gravel's now.
Very useful session, though. I think we have to carry on with this one and investigate more.
So, as it says here, information reports. The reports will be taken as read. And again, just thank you to everybody at the CCG for compiling the reports and giving us all the information that we're always seeking. So, over to you, members. So, the first one is the NHS Clinical Commissioning Group Performance Report. I don't see any hands up with anybody with any questions. Oh, sorry, Sarah Scott. Is it Sarah?
Sorry, I didn't take my hand down. Apologies, Chair.
No, likewise, we can't see your names, but at least we can see your faces. Okay. So the next one is the Integrated Care System Report, ICS, the incoming thing. Any questions or comments to note? And finally, the report from
Barrel has
Mary. Sorry, Councillor Barrow. We're on item 7B, up to 7B.
A couple of questions around 7. I'm not sure which is 7A and which is...
It's on the agenda. So A is the Clinical Commissioning Group. B is the ICS report.
Right. Okay. I just wanted to ask. I think it comes into the first part actually. So I might have missed you there. About the progress to set up a rapid diagnostic service in cancer. That was something that seemed quite important to me, and I wondered how that was getting on. And then I've got a question about the survey that the ICS is doing.
Sorry, the first point, the rapid access diagnostic. Which paper, sorry, did you say that this was in? Sorry, I haven't got it in relation to my to the paper. There's mention of it when talking about the cancer. You've got your green, your amber, you've got your red, etc. Okay, I must confess I'm not. There's quite a lot of different sections to this. I'm not exactly sure which bit that refers to, but I do know in general, and I will ask Simon if he's got any comments specifically about the trust. We are doing a huge amount of work on diagnostics across the county. So Gloucestershire has received significant investment from the Community Diagnostics Programme. So we're looking to develop and put in a hub which will be part of our diagnostic strategy in the community. Which not only gives us more diagnostic access overall, but obviously by taking some pressure out of hospital diagnostic services, we hope to free up capacity for the hospital as well around pathways such as cancer pathways and so on. So there is a huge amount of work going on in diagnostics in Gloucestershire, looking to expand our capacity quite radically. So Simon, do you want to add anything in particular about what you're doing in the Acute Trust?
Only just linking back to Stephen's previous comment about the investment at Cheltenham. So not only additional capacity, but the latest equipment as well. So it means we get better and quicker diagnostics results through to patients. So that, as Helen said, you've got two things running in parallel. Additional capacity in the community, so we can divert those patients into community facilities. But the latest technology then in the acute, which means you get more accurate and quicker results. So both those things running in parallel help.
I think there is. So I've been quickly flying through the papers to try and find your reference, but I can't.
Sorry.
Okay. Stephen, Councillor Stephen Andrews.
Thank you, Chair. I'm in a different area of questioning or comment at this stage. Really to thank people for all the information that there is about unscheduled care and so on. But actually, I'm holding my fire on that particular thing if we are going to hear from with Swast here, because I think, and 111 here as well, because I think it will be useful for us to look at all of those measures together, although I don't see Eve here at the moment, as a system, as part of the system.
Okay, anybody else? Anybody else? Okay, so have we dealt with item 7, A, B, and C, the list? Everybody else, members, virtual, people in Charlotte? Okay. Are we okay to move on to item 8? I don't see any hands going up at all. Don't see any hands old or new. No? Okay, so item 8. Obviously, we've all read these, and I just thank the people who wrote the ones on item 8 for making them as clear and as non-technical as they could. They cover some pretty serious and complicated medical issues, but I find them pretty easy to read and to understand, quite lengthy, but that adds to the detail. So are there any questions or comments on the temporary service changes at item 8 on the agenda, please?
Did Helen, do you want to just go through a little bit, just a quick summary?
Well, I don't see any people putting their hands up, so I'm quite happy to move on.
It's just that on page 125, we do the committee. The host members do need to give a little bit of an endorsement that they've noted.
No, sure.
Okay, so it's
okay. I'm
page,
happy to
page 125 for host members to particularly refer to. Helen, do you want to just sort of give
I can
quick,
do. So, I mean,
here.
As Andrew said, hopefully the paper is quite self-explanatory. Okay. So we are talking about the COVID-19 temporary service changes, and as you will know, we brought some of these in during the pandemic. We list at section 2.1, which is on page 119, those which have reverted. So those are now back to their original configuration, and that included things like the changes to the CGH emergency department, which was obviously of significant interest to the committee, acute medical take, neurology, etc. There are, however, a small number of changes that we wish to continue to keep under the reconfigured change, not least because we are still working through the potential benefits that we've seen from some of these reconfigured arrangements. So the ones that we want to retain are around high care respiratory, which would remain at Gloucester Royal, hyperacute, acute stroke and rehabilitation to remain at Cheltenham General, and the medical day unit to remain at Cheltenham General. With regards to Gloucestershire Health and Care Trust, we plan to return the Vale to the original configuration, but just not yet, because there is a time frame around that being safely achieved. So we expect a time-limited extension. At the moment, we aim to reverse that in the summer, but obviously that still requires some work through. We also have to retain the closure of the DILC minor injuries unit, because the physical capacity of that building just cannot be adjusted to accommodate the social distancing measures. For those of you who've ever been in there, it's a very small space. But obviously we have the significant capital scheme in the Forest of Dean delivering a new state-of-the-art purpose-built hospital for the Forest, which will be exciting and also provide us with resilient facilities in that district. And then finally, the Stroud Minor Injuries Unit, which is intended to reopen in May 2022 on the completion of that refurbishment programme. So for the committee to note, it is the reversal of the changes that I've already described, the retention of a small number and the reasons for that retention.
Thank you.
I think that's really helpful. Thank you. I know David Drew's put his hand up. David, I know you had some concerns and some reservations at an earlier meeting, and I remember at that meeting the concerns you had were addressed. But I see, do you want to speak now? If you've got a question, comment, please.
Yeah, it would be the one that you picked up on. It's the Vale, which obviously I get lobbied on very regularly. All I would say is when we start making the changes and get the 6 community beds back again, can we make sure that the League of Friends are properly consulted? I mean, I'm happy to come down on site and see how this is going to work. I mean, clearly it is going to be more difficult to manage because I understand how the stroke unit has operated there, and it's had all 20 beds. So it'd be interesting to know how you will make the split and, what that does in terms of changing nursing numbers and the rest of it. So if we could get down on site and do that, that'd be very good.
Yeah, I think those are the points you made before, and well made, and communication is key. So, Paul Roberts, you're going to address those.
Yeah, briefly, we've obviously had some discussion with Councillor Drew in the past, and we keep the League of Friends up to date. We'll make sure they're involved in that process, and happy to take the points that Councillor Drew makes on board.
David, you've got it, okay? Well then, thank you. Thank you, Paul. Okay, Jill Mosley.
Thank you, Chair. I'm just a quick question about the new hospital in Forest of Dean. Last week, on Tuesday, as a member of the planning committee for the Forest of Dean, we were standing on the site of the new hospital, and it's coming this afternoon, which is why I'm going to have to leave if this meeting goes on too long, to the planning committee for hopefully approval. What I wanted to ask was, it's probably in some of the papers I should have read already, but papers are what they are. Wonder if we could just highlight the length of time it will take to become operational for the Forest of Dean. Thank you.
Okay, so I think Angela's going to deal with that. Angela Potter.
Thank you. So subject to the planning discussions this afternoon, and obviously, as you say, hopefully a very positive outcome to that, we would be looking to start our enabling works, so our groundworks, not the building itself, because there are planning conditions associated with that, as soon as possible. We are then looking at around a 75-week build programme, so it will take us to the end of 2023 in terms of construction, and then we will be fully operational from there onwards.
Good question, good answer. Okay. Anybody else? I see nobody else. And for the HOSC members, we're happy to note the changes. We're happy to note the changes. I've got agreement all around the table, so we move on. Is that okay?
Can I just say one thing?
Sure, of course.
Would you mind, Chair? Which I must apologise, I forgot to mention under section 7, and I don't want to get in trouble with Becky because she will tell me off, which is that we have an engagement which is currently live, and I was given very strict instructions to promote it, and I failed to do so. So if you could go online, we have booklets at the back, answer the questions. We'd love to hear from you. Then I would be really grateful, and I also won't be on Becky's naughty step, which means a lot to me. So
we certainly don't want to fall out with Becky, so well done. Okay, that's really good. Thank you. Thanks, Ellen. Thanks, members. So that takes us. I forgot where that takes. That's what I did finish.
Your break is called.
Pardon?
Your break. Sure.
COVID. Comfort break. Well, are you taking a vote on that? Because. Yeah, I get mixed with people, body language, people saying crack on, Stephen.
Okay, we'll crack on then.
It's body language I'm picking up. Okay, over to you. I finished my bit.
Item number 9, information reports for adult social care.
Start with the microphone.
Sarah, I think with the other reports,
we can't hear Joe. Sorry.
Sorry. Can you hear me now?
I can hear you, but we couldn't hear Stephen.
Okay. I think we've taken the reports as read, Sarah, unless there's anything you want to highlight at all.
No, I think they're quite self-explanatory, but happy to take any questions.
Yeah, just taking the reports as read, Stephen. If you want to just sort of.
Does anyone have any questions about Q3 performance? Dilys. Thank you.
Getting a flashing.
And it's green. That's red.
It's red now, right. Yes, thank you very much. Yes, it was just something I wanted to ask. I'm thinking about admissions to residential and nursing care for people over 65. I'm just wondering whether staffing problems within the community care section has led to more people having to be admitted actually into sort of permanent care, as opposed to being able to stay at home and have people come, people come in and help in that way. I was involved with a personal situation in which a lady could possibly have stayed at home a little bit longer, but I was told that it would take longer for a package to be set up than it would actually to get her into a care home. In her case, it was probably better that she went into the care home, but I was perturbed to hear that it was going to take quite a while to actually be able to set up a package of care for her if she had been, if it had been better for her to stay at home. Thank you.
So I think during COVID, we have experienced really acute staffing issues in adult social care. And the delay in arranging a package is not a delay on the part of the staff arranging it. It's trying to find the dom care workers who are free to deliver that package of care to that individual. So we know in a county like Gloucestershire, which is large and semi-rural in part, that we have difficulties in sourcing appropriate levels of domiciliary care in Gloucestershire. We know there is an issue, particularly in the Cotswolds. So at times, I think we do struggle to find care for people. And this is partly, and this has an impact on the acute trust, as we've discussed earlier on the agenda, in terms of people not leaving hospital as quickly as we would like. Sometimes they are put into a residential care bed for a short period of time whilst we arrange a dom care package. And I couldn't say for absolute certain that we've never ever put someone in a bed in lieu of a dom care package, and perhaps they have stayed there permanently, because we've dealing with many hundreds of people each week. What we do try and do in every case is trying to ensure that we do all we can to support people back to their former level of independence. Sometimes entry into a care home bed is the most appropriate thing, but our long-term strategy in adult social care has been to try and support people to stay in their own home for as long as possible.
Kate?
Thanks, Chair. Tim Harmon was before me, actually, and my questions are for item 9B, but I don't know if we're there yet. I'm a bit confused because I can't see the agenda because I'm on the machine. So could you let me know when item 9B, when we're talking about that, and Councillor Harmon was before me.
Tip Councillor Harmon in there. Tim?
Hello. Yes, thank you. Thank you, Kate. I'm in a similar position with regard to the agenda, so I'm doing this slightly from memory. I want to refer to the public health performance indicators, particularly on alcohol use and opiate use and non-use. The figures you've got there, again, as was the case last time, a little bit historic, but I think you'll see with the explanation in the right-hand columns, we are expecting some improvement. We did say at that previous meeting, which I referred to, that we would invite CGL, a guy called Steve O'Neill, to come and make a presentation to you, which will give you far better understanding of the issues. They're the provider. That has not been forgotten. We will schedule it. Because you've had such a busy meeting today, we didn't think we could deal with it today. And subsequent to that, I did make an offer that I think Lisa and possibly Kate to have a visit to one of the facilities which are either in Gloucester, Cheltenham or Stroud to see what they do, which would give you a better idea. So that's not been forgotten. and I hope that will help. And you can directly ask yourself. I should go again. I've been several times, and frankly, it's quite impressive. And I think it will give you far more of an insight than any report we can bring here.
Thank you, Tim. We must remember that. Something for the next. Kate, can you join?
I think if you want to go down to the next report, Councillor Hurst, I think we've done on 9A. I think we're moving on to 9B.
9B.
And if Mark wanted to say anything, we're taking the reports as read, Mark.
Shall we take his report as read, but he's able to answer any questions if necessary?
Yes, no problem at all, Chair. Happy to take questions.
Anybody got a question for Mark Priest, Chief Fire Officer?
I do.
Kate.
Yeah, thanks, Chair. I've really enjoyed this meeting. I have to say, I do feel a bit rushed through it. I know that we've got a huge agenda here, and I wonder if it should have been possibly 2 meetings, or maybe we could have all come into the room that we used in the council chambers, and some of it's quite hard online. Anyway, I do have some questions. The first one is a statement. I am absolutely gobsmacked that we have just, with funding cuts, that there are just 3 officers dealing with food standards for 2,832 food premises in the county, and enormous hats off to everybody dealing with that. That one's a bit of a statement, really. My first question is, it was talking about enforcement, and that county do the food standards and districts do the food hygiene, but there's no sort of automated sharing information, and that's quite labour intensive. So I wondered why there isn't, and if anything could be done about that. That's my first question. My second question is around novel foods. Now, I looked this up, and quite frankly, they're fairly horrific. It was things such as, I'm just trying to find my information on yet another device because I can't see the screen and be on it. So novel foods. New dietary ingredients, and including things like pure chemicals, GMOs, genetically modified foods, cloned animals, new technologies, etc., etc. So I wondered how these are put as food labels, because I'd want to know if I was eating those. That's my second question. And my third question, really, there seems to be a lack of pathologists. We just don't have enough. And I'm wondering, again, if we should write to government and ask. When my daughter was at university, she studied maths, and she got quite a few extra grants and things because she was studying something that people need. She was doing medical statistics and things like that. And some of her fellow students, I think they were studying physiotherapy, and their tuition fees were paid by government because they could see there weren't going to be enough physiotherapists. And I wondered if the same thing is happening for pathologists, and if not, because again, looking along the line, if we're short-staffed now and somebody's going to retire in March, then it's going to get to a sort of critical stage. So the first question about automated sharing, the second question about novel foods, and if there's more information around those, and the third about pathologists and lack of them.
Do you want to take those questions, Tim? Mark, sorry.
Yes, of course, Chair. In terms of automated sharing, that's something that's actually on our radar as well, that our IT systems do need updating over time. So that would be something we'd try and incorporate in the future specification of our IT systems. That is the case now, actually, that when our training standard officers go out in the field, if you like, they have to take written notes that they then update an electronic system when they get back. And our aim would be that they could have a tablet or device that synchronizes once they get back into the office. So that's something we're already looking at. In terms of novel foods, take your point about packaging and labelling, and happy to bring more information back to you, Councillor, or the wider group on what sort of information is made available about genetically modified food, clone food, and as such, so happy to take that on board. And again, in terms of the pathologist point, that's something we're exploring across the sector, particularly in the southwest region. We lead on the coroners group, and we can explore that and see whether we write as a region to the Home Office to encourage them to support pathologists. I don't believe their degree courses are subsidised, as you suggest some courses are. They get a bursary, don't they, to make it more attractive to the student, and I don't believe pathologists receive that bursary.
Thank you, Mark.
Thank you, Mark. Joe?
Could I just come back to Kate just to explain the purpose of the joint meeting? This joint meeting was arranged a long time ago, and I don't know if you're aware, but the council chamber is out of action and will be for about 6 months. It's going to be refurbished. So it's not ideal at all today, but it's the best we can do to have a hybrid meeting of the two committees. But hopefully you'll never have to endure this again because it's not been ideal, and we do appreciate everybody's understanding. But the purpose of the meeting was to go through a couple of items that both committees would appreciate or sort of value the information from. But the standard information reports, we were going to take as read because we would never get through them. And members were invited to submit any questions in writing before or after the meeting. So if there are questions that you want to submit after this meeting, please send them in to myself and I will refer them to the two chairs and we will get your responses. But it has been quite a unique meeting, so we do thank you for your patience.
Can I just say something to that, Chair? Do you mind?
No, certainly not.
Just briefly, I take that the chambers are out of action. I meant the room that we used last time for full council because that did take quite a few people. But the issue I have with submitting in writing questions in writing, etc. You know, if we're scrutinising, then and we're being filmed, or the public can look at these meetings afterwards. I think we have to be careful that questions written aren't lost. And also, I take the point about reports being read, and it would be too long, but there is a huge amount of reading plus extra links, not necessarily easy on an iPad. And it is very helpful, personally, to me when officers are able just to give a quick synopsis because it refreshes the memory, having read so many different reports. So I actually find that quite helpful. Thank you. But I do appreciate that it's...
Thank you.
Thank you, Kate. Anyone else have any regarding 9A through to D? Please.
I'm not sure if we've come on to this yet. It's a question, I think, which comes under public protection. Is that this one?
Yeah, that's this one.
This one. Lovely. Okay. Thank you. No, I'm just interested to read that there's going to be a new road safety policy and you're establishing a road safety forum. I've got a particular issues in the ward going on around road safety at the moment. So I wondered if you could tell us a little bit more about this. Thank you.
Of course, Councillor. Just to give you some background, there was a road safety partnership previously in existence when the previous PCC was in place, Martin Sewell. That did run into some difficulties and capacity and posts were removed from the structure, so that sort of like ceased to exist. Now Chris Nelson's come into being as the most recently appointed Police and Crime Commissioner. He's been meeting with Councillor Dave Norman, who's the lead cabinet member for the Community Safety Directorate covering road safety. They're keen to re-establish the Road Safety Forum, which is being re-established. From a fire perspective, we've had support from the County Council to create a new post, which is a road safety partnership education post, and that will start from the 1st of April. So there's a lot of effort and revigoration around road safety in the county, being led by Dave Norman, supported by Chris Nelson, as I was saying, and his Deputy PCC, Nick Evans, is going to be the joint chair of the Road Safety Forum with Dave Norman. Hopefully that gives you sufficient background, Councillor, for your question. I can obviously go into more detail, but conscious of time.
Thank you. So this is something that's going to happen in the near future.
Yes, it's being worked on now as we speak. It's been re-established, the Road Safety Forum, with colleagues from the County Council, Highways, Police and Fire Service in terms of our education teams.
Thank you, Dennis. Thank you, Mark. Do we have any more questions of Mark before the bells go down? No, thank you very much, Mark.
Thank you, Chair.
I think that concludes our agenda, doesn't it?
We've got two more reports, 9C and 9B, the Adult Social Care Report and the Public Health Report. If there's any questions.
They were taken as read, weren't they?
They were taken as read. If there's any questions for Sarah.
Do we have any questions of Sarah regarding the Adult Social Care Report and the Public Health Report? And Dillis.
Don't go away from me, can you?
No.
No, it was just, I'm so interested to hear about the various online services that's been going on for mental health for children and young people, because I see this as such an important area, particularly at the moment. But I am a bit concerned. I see that there are various sort of funding sources and various services. And it just seems to me that it's important that there's perhaps a more long-term establishment. It's just that I get the impression that there's something that's ending in March, and then there's something else which is finishing in April, and this sort of thing. Are there long-term plans for the online services? Thank you.
So we've always worked really closely with the CCG to commission services for what we call public mental health, to help keep ourselves mentally healthy rather than treating mental ill health. And at the beginning of the pandemic, we noted that there almost certainly would be an impact on the public's mental well-being due to the first lockdown, and little did we know what we were entering into. So we used some of our non-recurrent COVID money to commission Couth and Quell, the online open access services for young people and adults. Now, what we've done is, because the pandemic has lasted longer than we ever anticipated, we've extended those, and we commissioned those under special powers, whereby we can commission things very, very quickly and act outside of our normal processes, because we were in an emergency situation and we really wanted to get these services up and running. Now, we cannot extend the contracts for those services any further. We've exhausted the legal capacity of those contracts. We've got to commission them recurrently, which is a good thing, because we're increasing the capacity of our services to support people's mental well-being. So what you've got there in the report is an attempt to try and explain what we're doing to try and keep things going. So we have secured additional money through the medium-term financial strategy in the County Council, and that was approved at full council last month. So there will be a continuation of these services. But I think what it says, one service is ending. We're buying some more services from Teens in Crisis, Tick Plus, for a particular period of time whilst we commission a longer term service. So it probably is a bit complicated to try and explain, so I apologise if we confuse you, but essentially we will have a service in the longer term. It might look slightly different, but we're really pleased we're able to continue with additional service provision and more than what we had before we had a pandemic. It's good news ultimately.
Good, thank you.
Do we have any more questions of Sarah? It appears not. Thank you, Sarah, very much indeed. And that does bring it to the end of the meeting, does it not?
Yeah.
Well,
Well done. No, well done. Good.
thank you all very much for your patience. We've struggled through, we've got there in the end. So, in a bit it'll be good afternoon, but it's still good morning.
Just about. Thank you. Thanks, everybody. Thank you so much.
Thank you. Bye.
Thanks.